Hello, my name is Jeffrey Gannett, and I am a neuroradiologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, Massachusetts, and an assistant professor at Harvard Medical School. I'm presenting on our chapter, Radiologic Features of Central Nervous System Tumors, written by myself and Dr. Raymond Wong. Just as with surgery, where there's a methodical approach to a procedure, neuroradiologists have a methodical approach to reviewing brain MRI to ensure we see all findings that are either relevant or incidental to the expected or known pathology, and also to properly characterize the pathology. We'll go through the methodical neuroradiologist approach to brain imaging. We'll also give an overview of the common brain MRI sequences used in tumor imaging, and we'll give examples of typical features of several common intracranial tumors. T1 weighted imaging is one of the mainstay sequences in pretty much all neuroimaging examinations. In most places, a sagittal T1 weighted image is obtained to start. This gives a good overview of the midline structures, including the corpus callosum, the brainstem, the pituitary gland, the pineal gland, the cerebellum, cerebellar tonsils. In addition, many institutions also perform an axial T1 weighted image in the pre-contrast phase, and more commonly, these are being combined as a 3D imaging sequence, often an MP-RAGE sequence. The MP-RAGE sequence is a T1 weighted sequence that was developed primarily to look at differentiation between gray and white matter. So as in this case here, you'll see that there's really good gray-white discrimination in that center image. A mainstay of tumor imaging is also post-contrast T1 weighted imaging, and here on the right side of the image you'll see a T1 post-contrast image. And the T1 post-contrast images can be performed in a variety of different ways and are vary by institution. We typically perform a T1 MP-RAGE, and that's the most common method that is performed. It's a 3D T1 weighted image. It gives you thin 1 millimeter slices through the entire brain that you can then reformat into multiple planes. So typically you'll see an axial, a coronal, and a sagittal T1 weighted 3D reformatted image in the post-contrast phase. There are other sequences such as a T1 space or a vibe. You'll hear multiple different names for these depending on the vendor of the MRI machine. Each vendor has its own names for the similar types of sequences. They all have variable pros and cons to them. Your neuroradiologist will be setting up the protocols based on what sequences are available to them, and also based on current guidelines for different indications, and also based on what they feel gives optimal imaging with the type of machinery and the type of pathology that you see and have. T2 weighted and T2 flare imaging are also mainstays in pretty much every neuroimaging protocol. A T2 flare is essentially a T2 weighted image. However, using a special technique, the water signal is nulled. So free water, such as CSF water, is nulled, so it's going to appear dark. However, anything that would be T2 bright in the brain parenchyma still remains bright. Any type of gliosis will be bright. Any type of cerebral edema, whether it be cytotoxic or vasogenic edema, remains bright. So basically it takes away all the extra bright signal and it gives a better visibility of any kind of abnormality in the brain. T2 weighted imaging is really great for looking at the CSF spaces, including the ventricles and the basilar cisterns, as well as looking at the sulci. T2 weighted imaging, and not the T2 flare weighted imaging, but the T2 weighted imaging in particular, is also particularly of interest to many neurosurgeons. Lower signal, darker signal on T2 weighted imaging in a tumor tends to confer a more cellular or firmer tumor, whereas a higher T2 signal tumor, a brighter tumor on T2 weighted images, tends to reveal a softer tumor, something that would be more suckable. And the spectrum can vary, so you can have a meningioma, for example, that can have very low T2 signal and be very fibrotic, very difficult to remove. However, you can also have a meningioma that's very T2 bright and tends to be very suckable and very easy to remove. So the T2 weighted image that's done properly is really important in a lot of tumor imaging so that we can understand the consistency of the tumor. And, although there's been some publications on diffusion-weighted imaging and low diffusivity corresponding with cellularity, that's not necessarily corresponding with the consistency of the tumor. The data on this is not very great, however, it is consistent. Diffusion-weighted imaging is also performed in most neuroimaging exams. The image on the left here is a diffusion-weighted image. The image on the right is an ADC map. We'll get into that in a moment. But essentially, if you have bright signal on a diffusion-weighted image, what it's telling you is that there is less mobility of a water molecule in that region of the brain compared to other regions of the brain. So the brighter the area, the less a water molecule is able to move. The darker the area, the easier it is for a water molecule to move, or the more freely it moves. Now, when it comes to tumor imaging, so the classic is in ischemia, where you have an infarct, ischemic infarct. And an ischemic infarct is bright due to cytotoxic edema. The extracellular water ends up within the cells become really crammed together. There's very little, either a water molecule is trapped within the cell, or if it's in the extracellular space, that extracellular space is much smaller than it usually is. It's very hard for a water molecule to move between cells, as it would much harder than it would typically be. In the case of a tumor, a lot of people say that diffusion restriction or low diffusivity, or basically bright signal on a DWI in a tumor, is due to hypercellularity. And due to the small cells packed in a really tight space, highly cellular, again, small cells, the water molecule in the cell can't move very far, and the tightly packed small cells, the extracellular space is small, so extracellular water molecules also can't move very far. There is not exactly pathological evidence to confirm that. It does certainly seem to play a role, however, it is multifactorial. The ADC map on the right is a mathematical correlate of the diffusion-weighted imaging on the left, and one of the things that we need to look at when we look at a DWI image, and the DWI image shows a bright spot, we need to look on the ADC map to see if its corresponding opposite signal is dark. In a truly low diffusivity or diffusion restricting lesion, the ADC map will be dark. If the ADC map is bright in the same region that the diffusion-weighted image is bright, it's not a low diffusivity lesion. Usually it's a T2 shine-through effect that we call it. And if you look at the flare sequence or the T2 weighted sequence, you'll see a bright area in that region as well. And it's probably some type of gliosis or edema. So again, if you're looking for true diffusion restriction, it's bright on the DWI and dark on the ADC. Diffusion tensor imaging is a version of diffusion-weighted imaging. In basic diffusion-weighted imaging, like I was showing on the last slide, you get a DWI image and you get an ADC image. In diffusion tensor imaging, you'll get post-processed images that show the tracks of the white matter tracks throughout the brain. Now, diffusion tensor imaging takes longer to acquire and used to require special software. If you want to do reformatting, it does require special software, but most clinical software will now give you images such as these. And what you see is the white matter tracks are color-coded based on the direction of the fibers. And so the fibers that are going left to right are pink to red. The fibers that are going craniocaudal are blue to purple. And the fibers that are going anterior to posterior are green. And that's a convention in DTI. Now, just to be clear, DTI you cannot process DTI from any diffusion-weighted image or diffusion-weighted imaging acquisition. You have to specifically acquire images for DTI. When you perform DTI-weighted imaging, you can get the typical diffusion-weighted images and ADC images out of the same data set, but it doesn't go the other way as well. DTI takes more effort and more time to acquire. There are various opinions on whether DTI is useful in brain tumor imaging or not. When you don't do extra post-processing and you look at it this way, you may be able to see deviation of fibers or the location of white matter tracks relative to a tumor. However, the accuracy is not quite known. Perfusion imaging is typically performed only in certain specific indicated situations. It can be performed for ischemia, and it can also be performed in primary brain tumors. We perform it routinely for primary brain tumors at our institution. There are several different ways to perform perfusion imaging. You can perform it without or with intravenous contrast. In children with brain tumors, often the method without contrast is used. At our institution, in adults with primary brain tumors, we perform perfusion imaging called dynamic susceptibility contrast imaging, and this is what you see here. In this type of imaging, for the 60 seconds immediately following contrast injection, we image the brain continuously. The images to the far left in this slide show the acquisition data. We don't use those for clinical purposes. Those are reformatted into color maps, which you see. So the color map to the far left is the relative cerebral blood volume map. And what we're looking for in brain tumor perfusion imaging is we're looking to discriminate treatment-related necrosis from recurrent brain tumor. Recurrent brain tumor has elevated relative cerebral blood volume, and necrosis tends to have very low relative cerebral blood volume. So what we perform 3 different types of maps. You may only have one, or you may have multiple more at your institution. You'll have to get used to what's at your institution. What I'm showing you here is the relative cerebral blood volume on the left. In the middle is a leakage map, and on the right is the corrected relative cerebral blood volume map. That's basically taking the first map and correcting it for any leakage that's seen on the second map. And that's been shown to be more accurate in showing relative cerebral blood volume. These are all calculated by multiple algorithms, so you'll need to see what your institution is using and how accurate they are at your institution. Susceptibility-weighted imaging is performed at most institutions now. There's also another way to perform this that isn't quite as crisp and doesn't show susceptibility to the same degree. That's just called a simple GRE image. And we won't get much into these. These don't have a large role in brain tumor imaging. MR spectroscopy is an advanced MRI imaging technique clinically, and it can be used in brain tumor imaging, and specifically it is used to differentiate or to identify whether tumor is present in tissue or not. And so here you see a classic spectrum of choline, which is the CHO peak, creatinine, which is the CR peak, and NAA, which is the very tall NAA marked peak. And in non-tumor tissue, this is the typical ratio where choline is below creatinine and NAA is above creatinine. In a brain tumor tissue, choline, which is a marker of cell turnover, tends to be much higher than creatinine, and NAA, which is a marker of viable neuronal tissue, is much lower and typically is lower than creatinine. So it inverts the choline-creatinine-NAA ratio. In this case here, you see where the voxel is placed, which is just posterior to a resection cavity in the right frontal lobe on some abnormal-looking brain tissue. And this spectroscopy in this case showed that there probably was not tumor in that region. It was just gliotic neuronal tissue. So now we'll go through a few somewhat classic cases. This is a case of a planum sphenoidale meningioma. On the left, you see a T1 post-contrast weighted sagittal image, and along the planum sphenoidale, over the tuberculum sella and into the sella, you see that there's a large homogeneously enhancing mass. Along the anterior aspect, you see there's a dural tail where the mass is creeping along the dura. This is a classic location and classic appearance for a meningioma. Meningiomas tend to be homogeneously enhancing. They tend to have a dural tail, and this is a great location for one where we see them frequently. The middle image is a T2 weighted image. You see a little bit of the tumor in the middle of the tissue there, surrounded by a lot of vasogenic edema in the bilateral frontal lobes. You can have a lot of edema around some of these meningiomas, not always, especially when they're smaller, but as they get larger, edema is a classic feature, and there's probably a mix of gliosis and of gliotic tissue within that edema as well. And on the far right, you see a sagittal CT image, and you actually see that there's some hyperostosis or reactive hyperostosis along the planum sphenoidale, and that's classic finding in a meningioma and supports the diagnosis of meningioma. This case was pathologically proven to be a meningioma. Here's another classic extraaxial tumor case. This is a vestibular schwannoma. You see on the image on the far left, a T2 weighted image. You see that there's some intermediate to high T2 signal in this tumor, showing that the tumor is relatively soft. Schwannomas tend to be high in T2 signal. It's a classic finding for them. Remember, a meningioma could be high signal if it's a softer tumor, but it could also be quite low signal if it's a firmer tumor. Meningioma also can occur in the CP angle like this. However, unlike meningioma, you see here, this tumor enters the IAC, or is probably even centered in the IAC and growing out of the IAC. A meningioma tends not to fully enter or fully fill the IAC in this way. In addition, meningioma tends to enhance a little bit more homogeneously, though not always. And finally, you don't see a dural tail on this lesion. You see this is more of an ice cream cone shape coming out of the IAC, but well defined in that central post-contrast T1 weighted image. On the far right image, you see a coronal image through the same area. In that left IAC, you see the tumor filling the IAC and coming out into the left cerebellopontine angle. Here we have a primary CNS lymphoma. On the far left image, it's a CAT scan non-contrast image, and you see that the lesion is actually hyperdense or isodense to gray-white matter, maybe a little more dense. That's typical for a lymphoma where it's a higher density on CT. Then you see a T2 flare image where you see this mild high T2 flare signal that's pretty homogeneous throughout the lesion, along with some mild surrounding vasogenic edema. And on the ADC map, we don't have DWI in this case series here, but on the ADC map, you see that there's low signal. Even though there's high signal on the flare, there's low signal on the ADC map, which is showing that there's low diffusivity in this lesion. And low diffusivity is typical for a CNS lymphoma. Now, you can also see low diffusivity lesions in high-grade gliomas and other primary brain tumors, but that is a feature that is going to make us think maybe this is a lymphoma. And then in the far right image, you see a nice, pretty homogeneously enhancing region of this tumor, and all of these features where it's expansile, there's very mild edema around it, it's low diffusivity, and it's homogeneously enhancing without any necrosis would make us say, hey, you know, there's a high likelihood that this could be a CNS lymphoma and not a primary CNS tissue glioma. So think about biopsy as opposed to resection. And in this slide, we have metastatic melanoma. The two left images are pre-contrast T1 and post-contrast T1 weighted images. You see there is some high intrinsic T1 signal in the lesion along the lateral part, and along the medial part, if you look across the multiple sequences of images, you see that there's some susceptibility in the bottom middle image, and you see there's some intermediate T2 flare signal in that region of the mass in the T2 flare image in the middle upper image. And this all shows that the mass is hemorrhagic. So there's an underlying tumor here that has hemorrhaged, and the susceptibility really shows where the hemorrhage is. And then as you look more at the brain, there's a T1 pre-contrast image on the upper right and a T1 post-contrast image on the bottom right. You see there are a couple more enhancing lesions in the in the left occipital lobe and left temporal lobe. And you see that left occipital lobe lesion actually has intrinsically high T1 signal on the pre-contrast weighted image. And high T1 signal can be seen in melanin or in hemorrhage. In this case, it's probably either melanoma metastasis that is high in melanin or a melanoma metastasis that has had very mild hemorrhage. Here's another case of a spectroscopy image. So this is a patient that had an IDH mutant glioma. And here the spectroscopy voxel you'll see is over the right frontal lobe. And what you're seeing here is a very high choline, much higher than the creatinine, and then a low NAA, lower than the creatinine. This is that inverted appearance that I had mentioned earlier in the presentation that is classic for a glioma. In addition, we are able to perform measurements to look at the level of 2-HG in the region of tumor, and 2-HG is a correlate for IDH mutations. If 2-HG is high, it indicates an IDH mutation. And in this case, we're seeing the classic clinical features of inverted choline-creatinine NAA ratio, as well as an elevated 2-HG based on quantitative measurements, all confirming that there is indeed recurrent IDH mutant glioma in this section of the brain. Here's a case of glioblastoma, and on the far left T1 post-contrast image, you see a highly centrally necrotic tumor with peripheral nodular enhancement, which is often what a high-grade glioblastoma looks like. And in the middle image, what I'm showing is a functional MRI image. This is a sagittal functional MRI image. And what you're seeing is a little bit of activity in Wernicke's area, in the receptive language area. And in the anterior aspect of the frontal lobe, anterior-inferior aspect of the frontal lobe, you're not seeing much activity. And this patient had been having speech issues. And you're not seeing much activity, probably due to decoupling related to, due to neurovascular decoupling related to the tumor in this region. But we do know from looking at the whole brain that this person did appear to have left dominant speech centers. And in the far right image, what you're seeing is a post-processed diffusion tensor tractography image. And you're seeing in that multicolor arc there, that's the arcuate fasciculus, and showing that that goes right to the speech area where the tumor is located. The tumor is in yellow there. Now, this is not the type of DTI image that you would get right off the scanner. This has been post-processed, but it does show you what can be done, and whether it's helpful or not is debatable among different groups of neurosurgeons. And finally, we have a case of glioblastoma pseudoprogression. I want to show the use of perfusion imaging here. So on the far left, we have a T1 post-contrast image. This is the first post-operative scan. You see there's a bit of enhancement around a resection cavity, which is common. And then on a follow-up scan, here we see that there's new nodular enhancement anterior to the resection cavity. And the question here is this recurrent glioblastoma, or is this treatment-related necrosis? And on the ADC map, we see that there's no low diffusivity. So if you look in that region of nodular enhancement, there's actually some high signal on the ADC map there. Remember, on the diffusion-weighted image, you may see high signal here as well, but we don't want to get faked out. So we're going to look at the ADC map and see if there's low signal on the ADC map. If the ADC map was dark, that would indicate probable high cellularity. And now don't be fooled. You can see dark ADC signal on necrosis as well, especially if there's a lot of central necrosis. But in this case, we're not seeing any low ADC, and we would expect low ADC in recurrent high-grade glioblastoma. In addition, the far right image shows a perfusion image, and we see there's no elevated relative cerebral blood volume in that area. If this was a high-grade glioma recurrent, we would expect elevated relative cerebral blood volume in that area. So all of the imaging features in this case, aside from the nodular enhancement, favor treatment-related necrosis. And this would probably be amenable to watching as opposed to intervening, provided the patient's not overly symptomatic. So thank you for watching this presentation. We went through a methodical approach to brain imaging. We went through all of the common brain MRI sequences that are used in tumor imaging and gave several examples.